In the years that I was in New Zealand, I asked hundreds and hundreds of midwives how they explained the partnership model to their clients, and less than 10% did. They have a pamphlet on partnership. It's 44 pages, and the word partnership is mentioned 145 times. So it's very important to the construct of the midwifery-led model of care. And yet, fewer than 10% of midwives explain it to the pregnant women. If they do explain it, this is what they told me they said, that they support women's choices and they want to know what the woman wants from them. And this is how a partnership is described. Let's look at what a midwifery partnership might ideally be. What do you have in your mind that's really important? What are the ideas? So we know that the idea in the New Zealand midwifery partnership is that women have choices and they should have an expectation of their midwife, who, as you learn in other videos, New Zealand midwives give expectant women 24/7 care, and they work with all pregnant women in New Zealand, not just low risk. So what's your idea? What are the words that you would use to express it? What are the actions you would expect both midwives and pregnant families to take? Are there policies or systems that you'd like to see put in place? And what would be the goals? So to dig further down into the New Zealand partnership, it's based on a premise, which is that pregnancy and childbirth are normal, natural, and physiological life events. Now, we've talked about the fact that these three simple words, normal, natural, and physiological, can mean everything's fine, or it can mean anything that could happen might happen. So New Zealand midwives and the natural birth advocates tend toward the former. They just believe that pregnancy and childbirth are just normal life events that rarely require medical care, and that because they're physiological and they happen to women, that therefore women actually know how to do it. In other words, just because we're pregnant, we know how to be pregnant. Well, we are pregnant. It's not like we have to know how. However, giving birth is a different form of activity. It's shorter. It's more intense, it's a one-off, and it transits the baby from inside the body to outside the body. So within this particular model that pregnancy and childbirth are normal, natural, and physiological, the implication is that women just need to choose what they want around their birth experience and then be left alone because birth is going to happen to them, and because it happens to them, they know how to do it. So therefore, the partnership model is really based on midwives just supporting women's choices. However, there becomes this bit of a pickle in this, doesn't it? One is the goals and objectives. So within this partnership model that's been in place since 1990, so we now have 30 years to look at this, a generation to look at it, the cesarean rate in New Zealand has gone from 12.9% to about 28%. So it's more than doubled under exclusive midwifery model of care for 98% of the pregnant families in New Zealand. So the question is how did this happen? Midwives remain the lead maternity care even when women are referred to as an obstetrician. So the idea that obstetricians are causing the rise in cesarean, I don't know. Is that accurate? Is midwifery care causing the rise in cesareans? Is that accurate? Does it matter if there's a rise in cesareans? What do we care about? If birth is normal, natural, and physiological, do we want more women to give birth at home or out of the hospital where there's no medical or very little assessments, monitoring, or procedures done? I don't know. It's what do you want in a partnership? And in living in New Zealand and looking at that partnership model and talking to midwives since 1996, what I brought into New Zealand and put into Common Knowledge Trust was an idea that a partnership was based on each partner having sufficient skills for the job or the task that they were going to do. And in our case, we included a third partner, which was the woman's literal partner, friend, or relative who was going to help her prepare for the birth of their baby and be with them during that birth experience. So we look at partnership as skills-based for everybody. Now, in New Zealand, given that the midwifery midwifery model has this logo that pregnancy and childbirth are normal, natural, physiological life events that rarely require medical care, we as a nonprofit, and I as the director of that nonprofit, are fine with whether or not there is medical care, because the families that developed Birthing Better and the concept had all different types of birth experiences, and what we knew was that when we had skills, we coped and managed better, we felt more in control, and we stayed on top of the situation no matter what was being done to us or around us. So I brought into New Zealand a concept and worked to encourage midwives to expand their partnership model to be a skills-based partnership. Because when you think of that statement that they have, that pregnancy, childbirth are normal, natural, physiological life events, and they rarely require medical care, then the first thing that comes to mind is, why do they feel, as midwives, they need to be trained for 4 years to be in attendance? It's something that they consider to be so natural, that just happens, and that women know how to do, and can be left alone to discover birth. Why do they go to school for 4 years? And the reason New Zealand midwives give me, which is common sense, is just in case. In other words, they're trained to pick up reasons that do become medical and might require an obstetrical referral. And that makes sense, because New Zealand midwives are not nurse midwives, they're direct entry, which means they perceive of themselves as being non-medical. Although when you look at all of their training is based on the present day maternity healthcare systems and what is considered to be appropriate in terms of assessments, monitoring, and procedures. And often those things, when they are done by a midwife, are perceived of as an assessment, monitoring, and procedures to safeguard the health and well-being of the mother. Whereas if those same things are done by a doctor, an obstetrician in the hospital, they're perceived of as interventions, unnecessary, and imposed on people. So we have a problem. And we know we have a problem. Within the partnership model, if we have one partner that has been gone to school for 4 years to learn skills, then why is the other partner, the birthing woman, just told, you know how to do this, all you need to do is make choices. And I'm going to try as a midwife to help you achieve the birth that you want. That doesn't seem to make common sense. It certainly didn't make common sense to us. And so we went to the College of Midwives and said, you will have a stronger partnership when you advocate that your clients self-learn birth and birth coaching skills. Now, when I first went to New Zealand, there were very few skills-based methods available or known there. To some degree, Lamaze and the Bradley method were. To some degree, Grantley Dick Reed, Childbirth Without Fear was. But really, our Birthing Better skills were the first to come into New Zealand, and at that point, they weren't in a mixed media format. They were in my head. Things like hypnobirthing and hypnobabies and calm birth and birthing within and the other skills-based methods hadn't been developed. And they hadn't been developed because, as I say in another video, when the skills-based childbirth trend of the 60s and the 70s, particularly in the United States, was replaced, not added to, but replaced by the choice-based system where skills were actively dismissed, that meant that no other skills-based method, with the exception of Birthing Better, was developed for a 20-year period until the 1990s. And they really weren't available technically until later, because the technology had to catch up with the ability to make these things digital. So within this partnership model, if families were encouraged to become skilled, would the cesarean rate be lower? We don't know. What we do know from the 30 years in the United States, when multiple millions of families my age took Lamaze and Bradley classes, and we used our skills, birth and birth coaching skills together, mostly in a hospital environment, we felt empowered. We felt good about our births, even though we had many assessments, monitoring, and procedures done to us. And many of us had issues that required increased medical care. we know from that experience that skills matter. And I talk about this in another video in this series about the H.A. Brandt study that was done in New Zealand in 1961 at National Women's Hospital in Auckland, where they did a study of 123 first-time mothers who were not risk evaluated for physical, emotional, or psychological issues, and a control group of 66 first-time mothers who were not risk evaluated. And these women were taught some skills and had a birth coach because fathers weren't permitted in. And the study shows that care providers loved working with skilled women, that skilled women felt infinitely better about their births than the control people, and that their babies showed healthier signs after birth than the unskilled women. So when we look at a partnership model, New Zealand is unique. All of maternity care is under midwifery guidance. All of the education, all of the guidelines to practice, all of the complaints about midwifery is under the College of Midwives. That's not going to probably happen in your country or your state. However, when you think about the partnership that exists with midwives in your state or your city or your country, what is that partnership based on? And what we're encouraging you to do is to base it on midwives having skills and women having skills and their partners who are going to help them prepare for birth and perhaps be at the birth also have a set of skills so that they work with their pregnant partner. This is a win-win for everybody because every human task, every human activity is best done when we have a set of appropriate skills. The skills a midwife or an obstetrician needs are different than a birthing woman needs to do the activity directly with her baby. Those skills can then be perceived of from the viewpoint of the birth coach who sees and hears on a moment-to-moment basis how that woman is responding or reacting to what is going on inside her and to and around her on the outside. So we want to grow a skilled birthing population, and we want the partnership model to be very strong. Now, some people say, which is accurate, I don't have the ability to have a midwife where I am. I have a general practitioner or I have an obstetrician. They have not talked to me about being in a partnership model with me. That's okay. From the 70s, we treated the partnership model from our end. We're in partnership with our care providers. We want them to be highly skilled in the work that they do. We need to bring skills to the work that we're going to do. We had an inkling of that when Lamaze and Bradley was taught in the United States. There was a very high societal expectation that American families attend the very first ever childbirth preparation classes. We had no choices back then, so we had skills. In the 80s, when I gave birth last, all of those skills were gone because natural birth advocates and famous authors talked about cows and cats weren't taught, women don't need to learn how to birth because it happens to us. We instinctively know how to do it, and that it's preferential for us to be left alone in order to discover birth again. But remember, we wanted our husbands with us because we didn't want to be left alone. We didn't have skills prior to Lamaze and Bradley. We didn't feel we coped and managed and worked through labor well. It just happened to us. And so having first skills made a difference. Now we can have a broader range of skills that are more adjustable and adaptable and sustainable for all births, from driving to the hospital, being prepped and having surgery for a non-laboring cesarean, to having a birth unexpectedly in the back of a taxi, or at home intentionally with or without a midwife, or in a birth center, wherever you birth, whether you're low risk or high risk. 100% of pregnant women are going to give birth. And we bring to our birth a partnership with everybody else we work with. Even our partner, if we're having a birth by ourselves with them, that's our partner. And we have to decide whether that partnership model is based on us becoming skilled so that we can do the activity, or whether we just let it happen. So we are advocating for the idea of a partnership to be that all the partners have skills appropriate to their task, and we include the birth coaches equally in that, so that there are 3 partners in birth. Whether the care provider elevates the third party or not, we elevate it. And we believe that the words should be simple. When you're pregnant, self-learn birth and birth coaching skills that you will use as the activity of birthing your baby unfolds. And those are the actions you take. You use your skills as your birth unfolds, no matter where you birth, no matter who is present, no matter the circumstances, your beliefs, your choices, your lack of choices, change of choices, or what happens to around you. The actions are to become a skilled birthing woman and a skilled birthing coach. The systems in place are self-learn them, whether you go to a class or learn online or go to the library. The policies aren't going to exist. And the goals of having this type of a partnership is that we feel more empowered by the activity that we do with our baby, whether it's the birth we wanted or the birth we had, whether it's the birth we chose or nothing like we ever would have imagined. In other words, we are in partnership primarily with our baby and our baby's efforts to be born. So let's all become skilled.